Good afternoon, is it on? Do I need it on here? Yeah? Okay. Good afternoon, everybody. It still works. I used that when I was caucus chairman of the Republican caucus. That's how I got the boys to be quiet. And it still works. That's the only kind of whistle I can do. It doesn't come out any other way. It is effective. Okay, we're running a little bit late because of the rain and people getting over here. It's nice to see that there's some actually empty seats because usually it's standing room only. So I will call this meeting of the House and Human Services Committee together, and we are ready to go now. Representative Chokas, I think that you have some group you want to recognize, and you are recognized to do that at this time.
Thank you, Madam Chair. Anyway, I've got a group of future farmers that are here to watch the legislative process. John Hagan and his wife are the advisors, and Mary Beth is the young farmer secretary, and the leadership, and I won't mention them by name because I already have in the House, but I would like for y'all to stand up
Right.
so we could recognize y'all here in the committee. And as I was talking with Madam Chair earlier, you know, this is where the rubber meets the road in the committee work. You know, once it makes it to the House floor for a vote, the hard work has already been done. So this is where you actually see the legislative process in action. But anyway, thank you, Madam Chair, and thanks, guys, for coming up.
All right, thank you, girls. As I said to you, I grew up in a small town in Texas, and we had your organization in my small school. I didn't participate on official business because my father brought home every orphan that he had on his farms, and we took care of it in the kitchen washroom, in the washroom outside the kitchen. So, and we even had a monkey come to live with us. A spider monkey came to live with our dog, and gave us many hours of entertainment. One of my classmates, out of my 22 numbered graduating class, 22, became a vet. The monkey on one cold Texas day got up under the car when my dad had drove in to try to get warm on the motor, and my sister started it up and soon after and broke the monkey's arm. My younger sisters cried the next morning because Daddy wasn't going to do anything, so they took the monkey to the vet, and the vet put a cast on the monkey's arm. And at that point, the monkey couldn't pick up its arm off the exam table. It was the first monkey the vet had ever treated. So, needless to say, he took the cast off, put an ace bandage around the monkey's broken arm, and charged my father $75 practically on his deathbed. He was discussing how terrible that was that he paid $75 for a monkey. So I grew up in rural Texas, and I appreciate what y'all do and how it fosters leadership. So thank you very much for being participants in that. Okay, now into serious things. I was trying to get myself in a better mood. We've said this before. All of you that are lobbyists, do not, everybody listening? Do not come to me 30 minutes before we come over here and tell me that you have problems with a bill and that you haven't spoken to the person that is authoring the bill. These bills weren't dropped yesterday. Now, when it gets close to crossover day, there could be one that's dropped a couple of days earlier, and it could be that way, but that's the exception to the rule. These bills have been sitting out there. The authors of these bills were willing to talk to you. My door has been open. Several people and lobbyists have come to me on other issues, and I'm setting up groups to try to iron out their differences. But don't come to me at the last minute and tell me that you have problems with a representative's bill that's going to be presented in this committee today. And the same goes if you're here representing a department. Do not do the same thing to me. These bills are out there. The authors will talk to you, and I will talk to you, but not at the last minute. Now, I don't think I should have to say that again. For lobbyists, you're getting the big bucks to represent your clients. Do your work. And for the state people, you're getting paid better than we're getting paid to do your job, so do it. So with that, we will move on. Okay, and on our agenda, House Bill 158. Representative Silcox, you want to go first? And just as an afterthought, I don't keep banker's hours. I was here till 7:30 last night. If somebody had come to me, I would have stayed till 8 or 8:30. So I'll just add that to the addendum. Okay.
Thank you so much, Madam Chair. I appreciate that, and I'm glad I didn't come to you 30 minutes ago.
Good idea. It wasn't pleasant.
I come to y'all today with House Bill 158, and I will say first of all that you may not be aware, but Georgia is actually #1 in the nation for the number of HIV cases, new cases per year. In 2016, and there is a sheet in your folder about this, in 2016, for example, there were approximately 35,402 people in the metro Atlanta area living with HIV. Approximately 1,513 of those were brand new diagnoses. There are currently approximately 3,500 to 4,500 people on Medicaid currently in Georgia with HIV. This law is needed because eligibility for the Georgia AIDS Drug Assistance Program, or ADAP, is not the same. It's very comparable, but it is not the same as Medicaid. This is largely due to the fact that ADAP and Medicaid only review these formularies once a year, and these drugs are either brand new drugs that haven't been approved, or they may be old drugs that were previously reviewed and rejected by those bodies. The key to management of HIV is compliance, because unless a patient takes their drugs for HIV every single day, they are not virally suppressed, the virus reproduces itself, and they can infect other people. And that's why I've specified in the bill that a single tablet regimen is so important. Evidence shows overwhelmingly that if someone is only required to take a pill once a day, that their compliance is much, much better than if they have to take multiple pills over multiple times per day. Each new patient costs Medicaid approximately $338,000 for HIV medications, but this is far, far less than the $1.79 million for a patient that is not virally suppressed. The average annual cost of treatment for one of these patients is $24,256. Patients with HIV complications do cost more than people without HIV, because if they are admitted to a hospital or a healthcare facility, there have to be special accommodations made for those folks. This bill will allow physicians to get patients into treatment quickly with the very most effective drug regimen possible. So I think this is a very fiscally responsible way and a very humane way to take care of these people around us.
To summarize, you are saying that HIV patients are treated on Medicaid,
Yes.
correct?
Yes.
So it's not starting anything new. They are entitled to treatment on Medicaid if they qualify for the Medicaid.
That's correct.
And are you saying that we, as a rule on our Medicaid program, require them to take multiple?
Presently, there are different regimens. There are single tablet regimens already out there, but some people are on a multiple tablet regimen, and this is not to say if that is what's working for them that they would be required to switch. It's just to say that this is what it's encouraged going forward because the compliance is so much greater.
Okay, questions from the committee? Representative Hawkins.
What's the cost difference on the multi-regiment versus a single dose?
It's actually less expensive on the single dose.
Oh,
Mhm.
okay.
Other questions? Okay. Do we have any, we didn't put a sign-up sheet, do we have anybody from the audience that is compelled to speak on the bill? Okay, not seeing anybody. What's the will of the committee? Okay, we have a motion to pass with a second. Is there any further discussion? Any of our committee members that want to ask questions or discuss it further? Okay, we have a motion of do pass on House Bill 158. Everyone in favor, say aye. Anyone opposed? I think the ayes have it, Representative Silcox.
Thank you very much.
All right, do you want to go ahead and present your other bill?
Certainly.
While you're down there, that is, okay, did we add it on? What's the number on that bill?
166, I believe.
166.
It's the genetic counselors bill. For those of you who were here last year, of course, this is a bill that passed the House. It passed the Senate committees. It just did not make it on sine die. And so this provides for the licensure of genetic counselors. Genetic counselors, of course, play an increasingly important role, particularly counseling in the areas of cancer treatment, prenatal and neonatal care, as well as cardiac care. Documented cases were presented to the Georgia Occupational Regulation Review Council, or GORC, who reviewed this bill all the way back in 2017 and did recommend licensure of genetic counselors because of their unique expertise and ability to advise patients, potentially saving many unnecessary medical costs, as well as potentially saving lives. There are currently, or at least there were, as of last year, approximately 89 genetic counselors in Georgia. A large percentage of these are hospital-based, and doctors appropriately refer patients to them directly for genetic counseling based on their family history. The rest of the genetic counselors actually work out in the field because now, the way it stands, there are many physicians practicing that did not receive any current genetic education in medical school because we've come so far in terms of genetics education. And cannot accurately interpret genetic data. So these counselors go out in the field to educate them on when and where to appropriately refer patients to genetic counselors that are hospital-based. Probably the most famous case of genetic counseling in the U.S. is that of Angelina Jolie, who actually had a double mastectomy based on the information from genetic counseling that she carried the same genes as her sister and her mother, who both suffered from breast cancer. Currently, 23 states require the licensing of genetic counselors, so we would certainly not be the first state to license them. With regard to rural health care, the licensing of genetic counselors is critically important at this point because they cannot currently be reimbursed for the very excellent telemedicine work that they currently are doing for free. Should this bill pass, I know some people have asked me about funding. The cost of this would be, as of last year, was approximately $67,000, but that would just be for the upstart of this. Going forward, of course, the licensing fees, it would pay for itself. So that is House Bill 166.
Okay, Representative Silcox, do I remember that the medical board, am I remembering correct, the medical board will take the genetic counselors under their
Yes,
branch, and that they had no opposition to the bill?
that's correct.
Okay, so that's where they would be housed, is under the medical board. Okay, questions from the committee? Representative Petrie.
Yes, thank you, Madam Chair. Representative Silcox, so the $67,000 cost, that is the cost of the medical board to manage this new
It's really just a
Licensure.
startup for them to have a person to get everybody, with all the paperwork, pay their licensing fees, and really just to start up the board. It's just a startup cost, but it would not be ongoing, like I said, because then going forward, the licensure fees that they collect, it would be self-sustaining.
Okay, and currently, just because it has been since last session, I may have forgotten some of this. So currently, how do these individual counselors, these genetic counselors, tell me how they operate today? Obviously, they're unlicensed, but help me to understand that a little better about. I
Right,
know they're
well-
obviously many of them working in hospitals, but
Right.
explain that a little more fully to me, if you would.
Well, and Katie Howard is here. If she wants to come forward, she actually works with Northside Hospital,
That
and
would be
she
great.
can tell you better about that than me.
Welcome back, Katie. I remember you from last year.
Thank you very much. I'm happy to be back. So we are board certified. So to become a genetic counselor, you have to have a master's degree from an accredited genetic counseling training program similar to physical therapists or advanced practice nurses. And then after that, you pass a board certification exam, and then you're required to maintain your certification through continuing education. So this would just be, and that would all stay in place. And then the license would just be on top of that for genetic counselors in good standing.
Okay. Representative Hutchinson?
Thank you, Madam Chair. I just had a quick question. Do we know, I'm sure you know, the ballpark about how much a genetic counselor makes in a year?
It varies. On average, I believe it's about $70,000 to $80,000 a year.
I just wanted to make sure we weren't giving fees a very low
Yeah, we
population.
appreciate that. Yeah, so thank you.
Representative Chokas?
Thank you, Madam Chair. Other than the master's program, what type of medical training do genetic counselors receive? I mean, y'all trained to be a nurse before?
Nope. So genetic counseling is its own degree program within a medical school. So my degree came from, I went to college or school in Virginia. So I was within the Medical College of Virginia, and there are graduate programs. So with PhDs and different types of training. So we are our own thing. So we are not nurses. It's a separate track. But about 70% of our course load is academic, and then 30% is clinical. So you have to have a lot of clinical hours like a nurse or any kind of other allied health professional. So you're in clinic working with doctors and other genetic counselors to get clinical experience, and you have to put all of that together before the board certification to show that you've had enough clinical experience to graduate and to sit for boards. So there's
this-
a lot of medical education.
So this is not, another certification for the nursing program or anything like that?
No, it's unrelated to nursing.
Okay, thank you.
Representative Chokas, it's a totally different area of medicine, totally out of the scope of what nurses would do in any way. Okay?
Thank you.
You're welcome. Okay, Representative Fry.
Thank you, Madam Chair. We may have answered this last year, but does this stop those, like the app on my phone, 23andMe and all that ancestry?
Sure doesn't. No, in fact,
Like,
if
there's
you
no
go
way for it to get caught up.
Representative
in-
Fry, where are you from? If you used it and,
Well,
No,
I
if
have
you-
some genetic information
No,
on my
Spencer, if you
telephone.
look on the very last page of the bill, it's on the last page, it's the next to, it's,
Oh, yeah, I got you.
subsection
That's what
4.
I was looking for the whole time y'all were talking.
Yeah,
Thank you so
any
much.
company providing services to consumers without seeing a physician or genetic counselor that are approved by the USDA can still
Good.
do their thing. And then the nutritional counselors wanted a special provision there too.
No, I appreciate
They didn't want to
that.
be cut out.
Yeah, thank you.
So
And Representative
So-
Fry, I just read an
just
article
show it to me.
about what's happening with these different things like 23andMe are the ones that delve in more to your genetic background. And because they are bringing up so many questions from people, parents and otherwise, that these companies are actually hiring people to answer the questions. But there was no mention of any kind of educational requirements behind the people that they were hiring to answer the questions they're getting. And since you might be discussing with parents either a genetic finding that would influence the children that were born if they marry somebody with the same genetic background, or if they found something wrong with a child's genetic background, what that would mean, I find that sort of on the really iffy area, and even more important that we have people that know what they're doing and have been educated on this.
Yeah, and in fact, if you call 23andMe with questions about your paperwork that you get back from them, they say, go find a genetic counselor. Here's where you go to findageneticcounselor.com, and that's a link to our national society. So that's actually where they send people with questions. And actually, a wonderful genetic counselor from Georgia just left to go work at 23andMe. So they're hiring genetic counselors themselves.
I hope all of them are doing that, and not just hiring somebody off the street and giving them a little training and letting them answer the questions. Representative Petrie.
Thank you again, Madam Chair. Quick question. And so where are we in Georgia, and what universities in Georgia are we producing these degrees, and how many do we turn out a year in this state?
Only Emory has a genetic counseling training program at the moment, and they just increased their enrollment to 11.
11 a year.
11 a year, which
Thank
is
you.
actually large.
Thank you very much.
Yes.
Okay, Representative Schofield.
So that was almost my question. Thank you, Madam Chair. How many do we have currently? So we only have 11 in the state, or is that all that Emory?
Yeah, there's about 90 genetic counselors living here. That is how many are graduating within Georgia
Okay.
every year is 11.
All right, thank you.
Yes.
Okay. I would take it that the background is pretty heavy in the sciences, that the same kind of sciences and all that the medical students take that often trip up a lot of people in college and trying to get into med school and the other areas like that. So that there's a very strong scientific requirement in this field.
And a lot of the times, we're teaching, the genetic counseling students are teaching genetics to the med students in a lot of these medical schools. That was my experience where I went.
Okay. Other questions? Okay, we've got everybody's questions. Okay, we've had the person from the audience. Is there anybody that is just dying to speak to this issue? Okay, not seeing anybody. What is the will of the committee? Okay, yeah, you're recognized to make a motion. Representative?
Thank you, Madam Chair. I recommend that I move that we pass House Bill 166, LC 337650.
I've got a second on it. All right, we have a do pass and a second. Is there any further discussion on the bill? Seeing none, everyone in the favor of passage House Bill 166, say aye. Anyone opposed, no? Well, looks like you're hitting 100 on both of them today. Thank you very
Thank you,
much.
Madam Chair. I have one friendly amendment very quickly
Ah,
on the very last line of the bill. The nutritional counselors,
wait a minute.
okay?
We just passed the
Okay,
bill,
okay,
like, no,
I'm
wait.
sorry.
Okay, is this something that you can do on the Senate side? Or does he
Yes.
have- What? On that vote?
Okay, can we entertain a motion? Could I make a motion to reconsider our vote to add a friendly amendment?
Well, yeah, as a member of the committee, you want to do that? Could I have a? Okay, I've got a motion for your lucky day. I've got a motion for reconsideration in a second. Any discussion? All right, everybody in favor of reconsideration, say aye. Anyone opposed? No. Okay.
Okay.
Now we're back to, we're going to have a, do I need to go through?
An amendment.
Okay. I
I'd
don't have
like-
to go back and do the bill. Okay. All right.
I'd
We
like
don't
to make a
usually-
motion now.
We don't usually have this.
I'm sorry,
You
this
are
is my
presenting the
bad.
bills. Hang on. Okay. We have that amendment wants to be presented. Present your proposed amendment.
Yes, I'd like to make an amendment to the bill, please, on line 233, the very last under subsection 5 and just insert the words, any company or individual. The nutritional counselors sometimes operate individually, so if we could add any company or individual, just those 2 words, I'd greatly appreciate it.
Okay,
And I got it. I messed it up.
okay. Do you have any problem with that? Or any person? Okay. Discussion on the proposed amendment. Okay. I'm good. You're good with it? Okay. Any else have a question on the proposed amendment? Okay, now, wait a minute. Who's 14? Oh, Schofield. Okay, it's the proper time. Do I have somebody that wants to move on the amendment? Not you. Okay, all right, the amendment be accepted. Do I hear a second? Okay, I have an amendment. I have a move and a second. Any discussion on the amendment now? Any more? Okay, hearing none. Everyone in favor of the amendment, say aye. Aye. Opposed? No. Okay. All right, the amendment passes. Now we'll go back to the bill. Okay. This is going to go out as a substitute, Betsy. Technically, it's a substitute. Okay. Everybody in favor of the substitute to House Bill 166, say aye. Anyone opposed to the substitute to House Bill 166? Okay, we have just passed the substitute to House Bill 166. You'll remember any time that we make any kind of amendments, basically, unless it's changing an A to an, it becomes a substitute. It's how it's carried out, not as amended. Betsy's not listening, but they want it to come out as a substitute, not as a bill that has been amended. At least that's, well, Betsy's. Betsy, is that still the way we want to do it? If we make any kind of amendment, we want it to come out as a substitute? Right, we'll incorporate whatever changes are made into a substitute. Right.
Thank you, Madam Chair.
Okay, you're welcome. All right. Okay, I'll call Representative Dempsey. Did I lose you? Okay, do you have a preference to which one you go first? Okay, how about House Bill 160?
That's great. Thank you, Madam Chairman, and thank you for these bills that you're revisiting so quickly that stumbled a little bit last year. It's time for us to show the strength of the House, I think, and move forward with many of them.
We're talking about the 41 bills that got held up on the last night of the Senate session for some unknown reason.
I know. It was a little awkward, but let's see what we can do. Let's give it a try.
Okay, let's get some of those bills we passed out moving.
Let's do. So back in around 2011, I was contacted by a local bariatric surgeon in my hospital who talked to me about a subject that I didn't really personally know a lot about, and that was on the challenges of obesity in our state. It was very important to him because that was his profession, as well as being a general surgeon. And as I began to learn more and more about it and the compounding health issues that occur when you are obese or morbidly obese, it was pretty heart-wrenching. So we began to work. In 2011 also, at about that time at least, I was still a pretty new legislator. I'd been here a little bit, but I was taking off a big bite to try to do this. I'll say that, and I encourage all of you to do that as early and soon as you can. But bariatric surgery had been a part of our state health benefit plan for some time. It was removed. And while other places might have been recognizing it and helping people get to the point that they needed to be healthier, it was not a part of our state health benefit plan. So we began to talk about it a little bit. And first of all, with the naivety, as I say, of the young member, I thought maybe we could talk them into putting it back in. Well, that didn't go so well. So we started talking about a pilot plan to begin to prove the facts. And we have been successful in that. We did have a 2-year pilot that was very successful. I think the statistics from that bear out that while there is a cost on the front end, no doubt. The later results that save us money, if you want to go to the money issue, which is what we're charged to do, no doubt, are very important, but the life-saving results that happen immediately, often before you even leave the hospital, and that involves diabetes wiped out. It involves high blood pressure taken away. Then as a patient begins to really accept and work through, because it is work. It's not just a miracle wand. It is work to change your life, to live that way as well. The weight comes off and the other health issues get better and better. So today, I bring to you House Bill 160. And it is a chance to revisit the pilot. Last year, I believe it was House Bill 646. This passed unanimously out of this committee, first of all, I want to say, and I thank you for that. But then it also passed on the House floor with overwhelming support and traveled over to the Senate and did not receive a hearing. So that was sad. It was sad that it didn't happen. But I think we can right this wrong today. This will allow for the surgical procedures for the treatment and management of obesity and related issues, and that's so important. It's just for the state health benefit. The specifics on it this time around, well, that it will be a 4-year program to start January of 2020, allowing a maximum of 250 individuals per year. The screening is tight and rigorous to get them to that point. The follow-up is intense afterwards. There are commitments now that you will have already been an employee for 2 years, that you plan with intention to stay for 2 more years after. There are 3 procedures, and I have an expert that will come explain those if there are questions about them that are allowed. I would encourage you to look at the bill. It's the same thing that we've been doing. It's a little bit like Groundhog Day in a lot of ways. The reporting is strong and good, and will begin 6 months after the program and follow up every 6 months for us. So at this time, I do have someone who is very much an expert in the field that I'd love to bring to the table to talk with y'all, and it's Dr. Shanita Johnson. You have a bio on her in your packet, but Dr. Johnson, if you'd like to come join us up here.
Welcome. Certainly
Yeah,
have an impressive
you do.
bio.
She does. Just a little bit of brief about you, Dr. Johnson. An associate professor of surgery, director of Morehouse School of Medicine and Grady Memorial in Atlanta, an experienced surgeon. She's very, very experienced, the director of minimally invasive robotic bariatric surgery. A graduate with many profound degrees from many great places. You will see is very sought after speaker and expert on this subject, so I'm very glad she could be with us today.
And Dr. Johnson, before you start on your subject, I just want to say thank you to working at Morehouse and at Grady. Our Morehouse Medical School is doing amazing things, and we are greatly appreciative of the fact that they are turning out many of the students not to be surgeons, but to be physicians on the front line of treating the total patient and family medicine and internal medicine and going to our rural areas. So thank you very much for the part you play at Morehouse in training a lot of our future physicians in an excellent way. So thank you. You've got the floor.
Thank you, Madam Chair, and thank you for this opportunity to speak on a subject that I'm passionate about. Obesity is widespread, it's expensive, it can be deadly. We spoke about the diseases that are involved. There are more than 40 comorbid diseases associated with obesity. Diabetes being one of the leading ones, and actually Georgia ranks 12th in the nation as far as diabetes. When we look at the healthcare costs, obese patients have a 42% higher cost than those of normal weight. And these healthcare costs translated into $480 billion nationwide. In the state of Georgia, those costs are $60.6 billion. The myth is that patients need to do just diet and exercise. But the studies show that if you have about 100 pounds of weight to lose, which is what the criteria will be for our patients, the chance of doing that and maintaining that weight loss is actually 1%. Bariatric surgery is the standard of care for the treatment of obesity. It is effective, it is safe and durable. It's endorsed by the NIH, American Diabetic Association, CMS, American Heart Association, and many others. There have been dramatic improvements in diabetes, high cholesterol, stroke, hypertension, the list goes on and on. We have seen the effect that it has had on life expectancy and quality of life. And I know this because not only am I a bariatric surgeon, but I'm a bariatric patient. So I can answer questions from both sides. I made the decision that my health was worth it for the investment in bariatric surgery. I had tried various diet plans and exercise. I had actually run marathons leading up to my surgery, but still could not lose the weight and maintain it. Daily, I saw the beneficial effects of the surgery on my patients, and I knew that this would be worth the sacrifice. Luckily, as a surgeon, I had the personal and family resources to make this investment, but many of our other state employees do not have access to the funds to do this. And Georgia is one of the few states nationwide that does not offer state coverage for this surgery. This bill will give them that chance to improve their health, and I'm so thankful to you for passing it last year, and I hope that we can do it again this year.
Thank you very much, Dr. Johnson. That was very impassioned and very appropriate. Thank you for sharing that. Do we have any questions for Chairman Dempsey or Dr. Johnson or clarifications at this time? Chairman Petrie.
Thank you, Mr. Chairman. Doctor, thank you for being here today. What is the cost? Because obviously when we add costs to the system, it affects premiums for all of our state employees. What is the cost for one of these bariatric surgeries?
On average, the cost for a cash procedure is something about $16,000 to $20,000.
16 to 20,000?
Yeah.
Okay.
But we do see that those costs are recouped within 2 years of having the surgery. The cost of medications decreased dramatically by 77% in some studies.
Thank you, Doctor.
Representative Henson.
Thank you very much. Thank you for being here, and Representative Dempsey, thank you for sponsoring this. Having been here quite a few years, I remember when State Health did cover this. I remember when the average cost was above $30,000, so cost has come down. And I met people back then who took advantage of the fact or did have the bariatric surgery. They're still with us today, that are living healthy lives, don't have the medical problems they had prior to having the bariatric surgery. And, you know, we all talk about many different things and that you can do. And I think bariatric surgery is one for reducing other health problems. One of the ones that you all didn't bring up is the orthopedic aspects, knees, feet, and so forth, and the costs there, which I think becomes a very great savings too, and something ongoing. So, you know, I'm totally supportive of this bill and have been in the past, and if you'd like me to make a motion at the appropriate time, I'd be glad to.
I'll be glad to recognize you at the appropriate time. I believe right now, Representative Schofield.
Yeah, so thank you very much for this bill. Thank you. I did vote for the bill last year, but I just wanted a question because I know a number of people that have had this type of surgery, and then the follow-up is sometimes with the excess skin, there is another surgery. Will this bill address any of that?
This does not
Okay.
address that. That'll be another step. You know, when we talk about this, though, one thing I want y'all to think about too and embrace is that private insurance companies cover this. Our insurance market makes it available. Medicaid covers it in all but 2 states, and that's Mississippi and Montana. And we are one of only 7 states right now that do not have it for their state health benefit employees. And that includes our teachers, it includes our school workers, as well as people that we interact with all the time.
Thank you. Representative Jones.
Thank you, Mr. Chair. I would like to say that I support this legislation as I have in the past when it came before the committee. And I did have this procedure in 2003 when I was employed with Lockheed Martin Company. So I wanted to make the motion, but I would like to second the motion that Michelle Henson is going to make for this bill. Thank you.
be more than happy to defer to Representative Jones to make the motion, and I'll second it.
This would be the appropriate time. Representative Jones.
Chair, I would like to make a motion that for a due pass on House Bill 160.
We have a motion and a second. Is there any other further discussion by the committee? If not, all those in favor of House Bill 160, LC 337619, vote by saying aye. Any opposed, no. And the bill passes unanimously. Thank you, Dr. Johnson and Chairman Dempsey. Don't go far.
Do you want me to do that?
Go ahead and stay. Yes. We're going to go do hers now, right? All right, thank you all. Let's go on down to House Bill 187. Chairman Dempsey, you may begin.
Well, thank you, and I'm glad we're looking at two different ways to approach the challenge now of obesity and the unhealthy situation, I think, that is the real underlying issue with obesity in Georgia. Our numbers are huge here across the state, there's no doubt. You've all heard that, and I thank you for your vote on the other measure. This is another pilot program, and last year, this also passed unanimously out of our committee. The same issue happened. It traveled well in the House with overwhelming support. It went over to the Senate with overwhelming support. It came back to us and it failed to be called up in the very last minutes of session. It's an important measure that I think was well supported, and I'd really ask for your support as we look at it again. But this is going to deal with the medication possibility. Not everyone is a candidate for or wants surgery. This is medication management, including counseling, a great deal of work, wraparound services serving that, to do another pilot to work on another avenue of trying to help people regain their health. And if you will follow me in the bill, you can see pretty easily that it is also, once again, purely for our state health benefit plan, where other opportunities exist in the other forms of insurance that are around right now. It deals with with a BMI of 27 with comorbidities or 30 without. So it would allow you to begin that process with that, to begin and ramp up quickly and be followed every 6 years very closely. This is for a 3-year pilot that would be for a maximum, again, of $250 per year to be involved with the Federal Drug Administration approved medications, to be followed closely and to see if we can help people become healthier in the same ways that we need them to with the previous bill, but perhaps those who do not have as an intense need or do not qualify for bariatric surgery. I do have an expert here as well to speak to this. Dr. Tammy Kell is here. If she could join me, please.
Please do join it at the table. Look forward to hearing from you.
Good afternoon. Thank you, Chairman and committee members. My name is Tammy Kell, and I'm a pharmacist with Novo Nordisk. We've been working with the state of Georgia for the past couple of years, and they've shared some of the demographic data that's specific to the state employees. For a total of about a little shy of 652,000 employees, 47% of those employees were reported with obesity, and according to their body mass index, and 31% were reported with overweight. Using a modeling tool with the state of Georgia specific demographics, it's estimated the direct cost for this population will be $18 billion and $1.8 billion in indirect costs, for a total of $20.7 billion over the next 10 years. Obesity is considered a disease and is becoming an epidemic that has health and cost consequences due to the complications that are brought on by obesity. A meta-analysis from 2016 concluded when a person makes appropriate lifestyle modifications, a prescription medication for weight loss increases the likelihood of achieving clinically meaningful weight loss within a year. And clinically meaningful weight loss is about 5% or more of your total body weight. and this will lower your risk of heart disease, diabetes, and other weight-related conditions. Thank you.
Okay. Sorry. I was working with the head of one of our other departments about a problem. Okay. Okay. Representative Silcox.
I know it's hard to estimate, but based on 250 people, but what do you think our savings would be if this worked?
Yeah, we actually don't have a return on investment modeling tool or simulation tool, so I don't have the answer to that, unfortunately.
It is important, though, that the numbers that were just given out, though, those are Georgia numbers. They're
Right.
based on the reality of what
Right.
would be spent in Georgia and what could be saved in Georgia.
Right. Just curious.
Over a 10-year period
Sure.
as well. I know the number, I watched everybody's eyes go really big when it hit the billions, but it is over 10 years.
Right, because when I looked at this bill, I just looked at it from a distance, and I think I need my glasses changed because I said, 20 million? And then we go, no, it's 20 billion. And I'm going, however, somebody in my family suffers from all the ravages of obesity in Texas, and there's no telling how much money that the Texas, because she worked for the Attorney General in Texas as one of the lawyers, and there is no telling how much is spent from helping her because of her problems with diabetes. It has to be close to $1 million, if not more, now because of the hospitalizations. And it would have been helped if we could have kept the weight in control. Representative Henson.
I was just going to say that at the appropriate time.
Okay, hang on, and we'll get it for you. Okay, Representative Hutchinson.
Thank you, Madam Chair. I was just curious how the 250 people would be selected.
If you'll look in the bill, just a minute, it will also tell you that it's a manner determined by the department. So it allows them the latitude to develop the policy for it. Everyone will have to apply that is interested. There is a screening process to check out your health completely and make sure that you would be hopefully a very good candidate.
Okay, do we have other? Okay, we've got another one. Okay. Oh, Representative Schofield.
Yes, thank you, Madam Chair. So I'm curious, I know that there are 5 drugs currently being used. What is the name of your drug?
It's called Saxenda, and the molecule is named liraglutide.
Thank you.
Okay, other questions? Okay, all right. Representative Henson, I think you are recognized at this time for a motion, please.
I'd like to make a motion that we move House Bill 187, LC numbers 33, 76, 23. And having been here and worked with State Health back when we did include this, I am interested to see it reinstated. So thank you very much, Representative Dempsey.
Do I have a second?
I have a question.
Okay, Representative Schofield,
Yeah.
now it's discussion again. Do you have?
I just had one follow-up question. So I just wanted, for my clarification, are all the drugs going to be used, or it's just this one particular drug?
All
Okay, thank you.
options.
Thank you.
Okay, I'm sorry. You were too slow with the question, or we were too quick with the update. Well, and we were pretty quick moving on, so I apologize for that. Are there other questions now that we have a due pass and a second on the floor before we vote on the bill? Any other discussion? Okay, everybody in favor of the passage of House Bill 187, say aye. Anyone opposed? No. Looks like the ayes have it. Thank you very much.
Thank you very much.
Okay, and I'd like to call, is Representative Frustration here? There you are. Okay, have you been here all this time?
I just arrived, so
Oh, good.
the important time with my
Okay.
it's called about approach.
Yes, you may, certainly. Okay, we have one more thing on the agenda, and it's House Resolution 135.
Thank you, Madam Chair, and the advocate's going to join me if that's all right.
That's, okay.
I bring to you today H.R. 135. This is dealing with ALS, which is commonly known as Lou Gehrig's disease. ALS is a progressive and fatal neuromuscular disease. From the time to diagnosis, or the time for diagnosis, is more than 12 months, and a majority of ALS patients within 2 to 5 years of receiving a diagnosis are deceased. And so it's a very fast-acting disease once diagnosis. The onset of ALS often involves muscle weakness or stiffness as early symptoms, progression of weakness, wasting, and paralysis of the muscles or the limbs and trunk, as well as those that control vital functions such as speech, swallowing, and breathing also follow. There is significant cost for medical care, equipment, home health care, and caregiving that's required for treatment of the disease. Under current law, and this is federal law, individuals must wait 5 months after becoming disabled before their Social Security disability insurance benefit payments will begin. Last year, Congress considered legislation that would eliminate the 5-month waiting period for disability insurance benefits for individuals with these symptoms, but unfortunately it did not become law. And so what I'm presenting to you here today is an urging resolution requesting Congress take action to immediately approve these benefits, because fast approval of these benefits are so very crucial to these patients. And if I could, Madam Chair, turn over the
certainly.
microphone.
Just tell us who you are.
Sure. Good afternoon, Madam Chair, members of the committee. My name is Sarah Imbro, and I'm the Executive Director of the ALS Association Georgia chapter. So thank you for allowing me to come today. We want to bring awareness and highlight the needs of the Georgia ALS community to you. But while we do that, our focus is to identify and provide resources that will enable the vulnerable community to experience the best quality of life while on this journey. ALS is a terminal disability with a life expectancy of 2 to 5 years if one is lucky. With no known cause, treatment, or cure, the medical focus is on managing the symptoms of a debilitating disease. It's a non-discriminatory disease, and it strikes without warning. There are no lifestyle choices that can prevent the disease onset. Thus, families are not prepared financially or emotionally to deal with the disease trajectory. Because of the debilitating nature of the disease, people diagnosed with ALS lose their jobs and employer-based insurance during the most challenging periods of their lives. They are without health care insurance until they can secure Social Security disability insurance and Medicare. Under current law, people with ALS who have been approved to receive these benefits are subject to a 5-month waiting period before Social Security owes the claimant disability benefits. This means that the Social Security Administration will withhold 5 months of an approved claimant's benefit before starting monthly payments. It's essential that those who have received an ALS diagnosis receiving disability insurance benefits as soon as possible, as 5 months can mean spending a significant portion of their remaining life waiting for their benefits to begin. And quite honestly, I have known families who don't even get those benefits before their loved one passes away. So what are we asking you to today? We ask that the Georgia House of Representatives urge our Georgia congressmen and women to support the ALS Disability Insurance Access Act. Georgia needs to show they care for those living with ALS in Georgia, so please vote yes on the resolution H.R. 135. Thank you.
Any? Okay, Representative.
Yes, I just wanted to commend Sarah Imbro, first of all, for coming down and being so active in this issue. I've met with her before and other friends, and appreciate Representative Chairman Upstration bringing this. I think it's a very important measure, and there's certainly a lot of people in my district that this has affected, so thank you.
Thank you.
Okay, Representative Sharper.
Thank you, Chairman. Thank you for bringing this. I've seen a lot of people deal with this in my lifetime. But we're looking at the 5-month waiting period to be eliminated. But do you know that even though they have the 5-month, is it retroactive if they get approved, and then do they go back, or are they just say, how does that work now?
It is retroactive, but what happens is while they're waiting and they've lost their jobs, they've lost all benefits, they have no way to make payments. So then other things start to happen. Evictions, loss of other bills that need to be paid, transportation. So it's a ongoing effect.
Okay, I just wanted that information just in case, you know,
It is
we get into
retroactive.
that, I can be clear on that. Thank you.
Other questions from the committee? Okay, all right. Representative Hutchinson?
Thank you, Madam Chair. I had a question about the 5-month waiting period as well. Is that a policy, or I know that it takes forever to get SSI. So is that a policy, and if it is, are we taking into account the amount of time it takes to get approved for it?
I'm not sure I understood your question. It is how the Social Security disability benefits are currently set with SSA.
My question is, so if we waive the 5 months, are they still going to be taking years and years and years to get approved for SSI?
No, so it should not. The point of doing this is so that what happens is once they are approved, there may still be a waiting period for approval, but once they are approved, they still have to wait the 5 months. And if by waiving the 5 months, once the approval happens, they automatically start getting their payments.
Gotcha. Thank you.
My understanding is that the 5-month requirement, that strict requirement,
Yeah, it
is what's really so difficult. With that being in place, there's no other option than to wait that entire 5-month period. And I didn't mention this before, but this impacts between 1,500 and 2,000 people living with ALS during that 5-month period at all times. And so this is impacting many, many individuals.
Do we have further questions? Oh, Representative Barr.
At the proper time, I make a motion to do pass.
Okay, hold on. Thank you very much. Thank you for bringing this. I had a look around, and we have so many new people. Do any of the representatives remember Elaine Myers? One of our favorite administrative assistants who retired. She died, I think, slightly over a year later from ALS. It was one of the very fast-moving cases that they had. And she had, I think, been retired 1 year. She came back and worked the desk out front where they send in messages and was with us for that. And then it was diagnosed and passed away very quickly. So it happens and hit home in our own sort of family here at the legislature. And I can tell you, you missed a special person if you didn't get to know Elaine, and because you're new and all, she was delightful to everyone that came. Okay, at this point, all right, Representative Barr, you are recognized to make a motion.
Make a motion to do pass House Resolution 135.
Do I hear a second? Oh, got lots of seconds. We have a motion and a second. Any further discussion? If not, everybody in favor of passing House Bill 135, LC 337631, say aye. Anyone opposed, no? And the ayes have it. And thank you very much to the committee. We are adjourned.